All right, well, why don't I launch us here today? So welcome to the Department of Medicine Grand Rounds on this Valentine's Day, February the 14th. This is a special treat in that it is not our usual every week to have a Nobel laureate speaking at Grand Rounds. So we're excited about that. And we have, again, a special treat today with Dr. Bill Kaelin. He is, if I read you his entire biography, he would not have time to speak. So I'm going to abbreviate that a bit and say that he is the Sidney Farber Professor of Medicine at Harvard Medical School and the Dana-Farber Cancer Institute. He's the senior physician in medicine at the Brigham and Women's Hospital and a Howard Hughes Medical Institute investigator. He obtained his undergraduate and MD degrees, unfortunately, at another institution in the Southeast, which was Duke, and completed his training in medicine at Johns Hopkins Hospital, where he also served as chief medical resident and a proud part of the Osler family. He was a clinical fellow in medical oncology at the Dana-Farber and later a postdoctoral fellow in David Livingston's laboratory, during which time he was a McDonald Scholar. Dr. Kaelin received the 2019 Nobel Prize in Physiology or Medicine. He's a member of the National Academy of Science, the American Academy of Arts and Sciences, the National Academy of Medicine, the American Society of Clinical Investigation, and the American College of Physicians. He's won many, many other awards as well, as you might expect, including the Lasker Basic Medical Research Prize. His research seeks to understand how mechanistically mutations affecting tumor suppressor genes cause cancer. And his laboratory is currently focused on studies of the VHL, RB1, and P53 tumor suppressor genes. His long-term goal is to lay the foundation for new anti-cancer therapies based on the biochemical functions of such proteins. His work on the VHL protein helped to motivate the eventual successful clinical testing of VEGF inhibitors for the treatment of kidney cancer. And this line of investigation, I believe, is what you're going to tell us the journey of today, leading to new insights into how cells sense and respond to changes in oxygen, which has really innumerable implications beyond the world of cancer, including into myocardial infarction and stroke. And so I'm really delighted to hear about your journey and really honored to have you as our guest today for Medicine Grand Rounds. And so thank you so much.
My pleasure. Thanks for inviting me. I'm sorry this is virtual. I look forward to perhaps visiting in person in the not too distant future. So here's the now obligatory disclosure slide. I'll try to mention relevant conflicts as I go along. Here's a list of the very talented young people who've worked in my lab over the years on von Hippel-Lindau disease. So I've been very fortunate in that regard. And here's a woefully partial list of the collaborators who have helped us along the way. So I have to say, I give enough research seminars that I actually jump at the chance when I'm asked to actually give a grand rounds. I enjoy giving grand rounds. When I was younger, I thought I was going to be a clinical doctor. As you mentioned, I did my residency at Johns Hopkins. Here I am. I think the first day of the internship, you can see all the coats are white and nicely pressed, and everyone has a tie on. Here I am towards the end of my intern year. The tie has been loosened. The white coat is gone. I'm probably a bit tired there, and I apologize for the cake, which of course is an Animal House reference. And I was so sure I was going to be a clinical doctor at this point in my life that I actually did, as you heard, stay on and did the equivalent of a chief residency year at Johns Hopkins. Here I am with my three fellow chiefs. They're called assistant chiefs of service. And I think you'll see this served me very well and in ways I certainly didn't anticipate at the time. So I did come to the Dana-Farber in 1987, dead set to become a clinical oncologist, but sort of by dumb luck, I wound up in the laboratory of David Livingston. Of course, that's one path to get board certified, is to work in a laboratory for a couple of years. And it was really David, who was a wonderful physician scientist. Sadly, we lost him in October of 2021, but he was my mentor and really responsible for me becoming a scientist. So I owe great debt to him. And my advice to the young people is find great mentors, no matter what you're going to do, because so much of both clinical medicine and science is really taught by apprenticeship. So I showed you this picture earlier. Some of you, maybe a handful of you, would know that this person in the middle there was Victor McCusick. who was the chairman of medicine at that time. And Victor instilled in all the house staff an appreciation for medical history, as well as an appreciation for the power of human genetics. So when I do give grand rounds, I like to begin this story where on one level it begins, which is this paper by Treacher Collins that was published in 1894. And Treacher Collins described a brother and a sister, both of whom had an unusual blood vessel tumor of the eye that we would now call a retinal hemangioblastoma. And about 10 years, and just again to show you what some of these look like, here's a patient with von Hippel-Lindau disease who's had a fluorescein angiogram, and you can see this large retinal hemangioblastoma filling with dye because of the vascularity. Now, a similar family was described about 10 years later by the German ophthalmologist Eugen von Hippel, and this was the great descriptive era in medicine. So frankly, if you could only read one literature at the time, many people were reading the German literature rather than the English literature. And for that and other reasons, this paper became more famous than the Treacher Collins paper, which is why it's now called von Hippel-Lindau. And here's the Lindau. So in the 1920s, the Swedish neuropathologist Arvid Lindau, who also, as you can see, published in the German medical literature, pointed out that these retinal lesions were really the tip of the iceberg and were often associated with other tumors, including hemangioblastomas of the spinal cord and cerebellum, paragangliomas, as well as kidney tumors. And so just to show you what a couple of these lesions might look like, in the upper left, I'm showing you the fundoscopic view of a patient with von Hippel-Lindau disease. It's nice that with this audience, I don't have to point out that this is actually the normal optic nerve, but here's the retinal hemangioblastoma. As I alluded to a moment ago, it's easier to see these lesions if you inject the patient with a fluorescein dye. And again, these patients can develop many retinal hemangioblastomas, and if they're neglected or grow too large, they can cause retinal detachment and blindness. Diagnosed at this early stage, they can often be managed with a laser. But again, it was Lindau who noted that these retinal lesions were associated with other lesions. So here's a sagittal MRI of a patient with von Hippel-Lindau disease. Again, for orientation, not necessary for this audience. Here's the lateral ventricle, but here's a very large cystic hemangioblastoma with the solid component shown enhancing here. And here I'm just pointing out that these VHL patients can also develop kidney tumors, and they usually, but not always, arise in pre-neoplastic renal cyst. So here the urologist has opened a large renal cyst and has discovered a clear cell renal cell carcinoma, which is the most common form of kidney cancer, arising from the epithelial cells lining this cyst cavity. So here are a number of these VHL families that have been followed at the National Cancer Institute. And I should point out that this disease affects about 1 in 35,000 people. I've already now introduced to you the sort of some of the classical tumors seen in this disease. So we talked about kidney cancer, the hemangioblastomas, paragangliomas, and of course, when paragangliomas arise in the adrenal gland, they're referred to as pheochromocytomas. So you can see from these pedigrees that clinically this looks like an autosomal dominant disorder. As we're going to discuss in a moment, at the molecular level, it's actually caused by a recessive mutation. So fortunately for me, shortly after I finished my postdoctoral training with David Livingston, I started my own laboratory in 1992. I was sort of thinking about what I might want to work on as an independent investigator. In David's lab, I had worked on the retinoblastoma tumor suppressor gene, so I thought I actually knew something about tumor suppressor genes. And so lo and behold, one fateful day, this paper crossed my desk, which was the isolation or cloning of the gene that, when mutated, gives rise to von Hippel-Lindau disease. And partly because of my clinical training, I thought this would be a great problem to work on, as I'll now elaborate in the next few slides. So I should point out, first of all, so we're all on the same page, that I mentioned that clinically this looks like an autosomal dominant disorder, but molecularly it's actually caused by a recessive mutation. So individuals with von Hippel-Lindau disease have inherited a defective copy of the VHL gene from mom or dad. In this schematic, it's the maternal allele, which is defective. But initially they're okay because they still have a remaining wild type allele. But unfortunately, if you're born with a defective VHL gene, you have a 90% probability that a susceptible cell in your body, such as in the eye or the kidney, will spontaneously lose or mutate the remaining wild type VHL allele, and that's the cell that will then go on to form a tumor. And as you would predict from the knowledge that germline or inherited VHL mutations predispose to, for example, clear cell renal cell carcinoma, if you now look at non-hereditary, that is to say sporadic clear cell renal cell carcinomas, you again see that both the maternal and the paternal VHL alleles are almost invariably mutated or missing. But here, both mutational events, or hits, if you will, have occurred sometime after conception, in contrast to VHL disease, where the first hit has been inherited from mom or dad. So all this is to say, this is a very well-behaved so-called Knudsen 2-hit tumor suppressor gene. So again, I thought working on the VHL gene would be a good idea for a young faculty member. I thought, first of all, everything else being equal, why not work on a common cancer as opposed to an uncommon cancer? And I just told you that mutations in the VHL gene give rise to the most common form of kidney cancer. And kidney cancer, as it turns out, is one of the 10 most common cancers in the developed world. So that seemed like a good idea to try to use the VHL gene to understand the pathogenesis of kidney cancer. I also knew from my clinical training that the tumors seen in VHL disease are highly angiogenic. Now, I've already shown you the picture on the left, but an old clinical saw is that kidney cancers are also notoriously rich in blood vessels. In fact, prior to the widespread availability of CAT scanning, the diagnostic procedure of choice in patients suspected of having a kidney cancer was to do a renal angiogram and to look for the characteristic appearance of new blood vessels throughout the kidney. So I hope that by studying the VHL gene, we might also learn something about the molecular control of angiogenesis. And I should tell you that the early 90s were really a period where there was a lot of excitement about the notion that you might eventually treat cancers by blocking angiogenesis, something that was championed by Judah Folkman, among others. But I thought if the promise of angiogenesis inhibitors were going to be realized, we actually had to first understand the molecules that really controlled angiogenesis so that we could develop drugs with defined mechanisms of action. And then finally, and I showed you this picture earlier, there's, chief residents love rare eponymous syndrome, so that if interns or students step out of line on rounds, you simply pepper them with questions about diseases like von Hippel-Lindau disease, and very quickly you reestablish that you're the alpha dog on rounds. But if there's one thing chief residents like more than rare eponymous syndromes, it's long differential diagnoses, somewhat for the same reason. You can terrorize your trainees with your knowledge of these very long differential diagnoses. So I had memorized lists like this as a chief resident. These are causes of excess red blood cell production. Clearly, some of these are adaptive, such as if you move to high altitude or if you have certain chronic lung or cardiac conditions. But another curiosity is that certain tumors are sort of known for causing excess red blood cell production due to their ability to ectopically produce erythropoietin. And it always struck me as curious that the 3 tumors associated with von Hippel-Lindau disease make this list, especially given that cerebellar hemangioblastomas and pheochromocytomas are relatively rare. So taken together, again, from my clinical training, I knew that VHL-associated tumors were highly angiogenic, and that's because they often overproduce vascular endothelial growth factor. And I just told you they sometimes cause excess red blood cell production because of the ectopic production of erythropoietin. And what VEGF and erythropoietin have in common is that they're normally induced when cells or tissues are not getting enough oxygen. So my dream circa 1993 was that by studying the VHL gene, we might be able to actually understand the molecular circuits that control oxygen sensing, because it seemed like somehow the oxygen sensing mechanism in these tumors was altered or had been hijacked by the tumors. Now, we knew from the work of many labs, including the labs of my fellow laureates, Peter Radcliffe and Greg Semenza, that many of these so-called hypoxia-inducible genes, such as VEGF and erythropoietin, are under the control of a heterodimeric transcription factor called hypoxia inducible factor, or HIF for short. And we knew from their work that the alpha subunit was normally degraded when oxygen was plentiful and only accumulated under hypoxic conditions, hence hypoxia inducible factor. And over sort of the next decade, our lab and others showed that the VHL protein is part of a so-called ubiquitin ligase complex that in the presence of oxygen binds directly to HIF alpha, covalently attaches a polyubiquitin chain that then targets HIF alpha for proteasomal degradation. Whereas when oxygen levels are low or the VHL protein has been mutated, such as occurs in kidney cancer, now HIF alpha can accumulate, dimerize with its partner protein, which is variably called HIF beta or orange, and activate various HIF target genes such as VEGF. So that was satisfying because it explained why tumors lacking the VHL protein might overproduce VEGF and on occasion erythropoietin. But it begged the question, how does the VHL protein know, if you will, whether oxygen is or is not available, and hence whether it should target HIF alpha for destruction? And in work that our lab did and Peter Ratcliffe's lab did, working independently and in parallel, we discovered the signal was hydroxylation of one of two prolyl residues in HIF alpha. So when oxygen is present, one of two prolyl residues gets hydroxylated, and this then generates a high affinity VHL binding site. And the enzymes that do the work here are variably called the EGLN or PhD prolyl hydroxylases. They split molecular oxygen and use one of the oxygen atoms to hydroxylate HIF alpha. And I should also point out that these enzymes have a relatively low oxygen affinity, so they're exquisitely sensitive to changes in oxygen availability over a physiologically relevant range, which is why they act as oxygen sensors. These enzymes also require reduced iron, which explains some of the paradoxical effects of iron chelators, at least in the laboratory, being able to mimic a hypoxic response. And they also require a cofactor, which is variably called 2-oxyglutarate or alpha-ketoglutarate, that thing you perhaps memorized when you were memorizing the Krebs cycle. And 2-oxyglutarate gets decarboxylated to succinate during the hydroxylation reaction. Now, there are three members of this family: EGLN1, EGLN2, and EGLN3, and I give you the alternative names here. But clearly, in most tissues and under most circumstances, EGLN1 is the major regulator of HIF, and perhaps for that reason, at least if you're a mouse, you can't make it through embryogenesis without EGLN1, whereas to a first approximation, EGLN2 and EGLN3 are sort of backups to EGLN1. Now, it turns out there are some families around the world that develop excess red blood cell production or polycythemia on a genetic basis. And the studies of Frank Lee at Penn and Joseph Percal at Utah and others has taught us that many of these families actually have mutations in this oxygen sensing pathway I just alluded to. So some of these familial polycythemia families have homozygous, or less commonly compound heterozygous, hypomorphic VHL mutations. This is called Shuvash polycythemia. So these mutations cause a very subtle defect in HIF regulation, as in contrast to the ones linked to von Hippel-Lindau disease generally. Yet other families have heterozygous hypomorphic mutations in the prolyl hydroxylase, and other families still have heterozygous gain of function mutations in HIF2 alpha. And I should also point out that polymorphisms in these genes have also been described in human populations that have adapted to life at high altitudes, such as in the Andes or Tibet. So there's very good genetic evidence that this is the oxygen sensing pathway, at least with respect to the control of HIF and red blood cell production. Now, I mentioned that these enzymes, these prolyl hydroxylases, require a cofactor called 2-oxyglutarate, and it turns out there's a very deep pocket that even I can appreciate in EGLN1 that normally would accommodate 2-oxyglutarate. And with that knowledge, a number of companies, and I think this is work from Amgen, have developed chemicals or potential drugs that combine to this pocket and prevent 2-oxyglutarate from entering the pocket. So these have been designed to be inhibitors of the HIF prolyl hydroxylases. The idea being that these drugs in principle would stabilize HIF and would turn on red blood cell production, which might be useful for the treatment of anemia in certain settings. Now, We actually reached out to a biotech company about 20 years ago called Fibrogen, and I declare my financial conflict of interest. They at the time were developing inhibitors of the collagen prolyl hydroxylases as potentially antifibrotics. And so we asked them whether we could test some of their compounds to see if some of them already were capable of inhibiting the prolyl hydroxylases that mark HIF for destruction, because if they did, that would be a good starting point for developing more specific inhibitors. And so here's an early tool compound they provided us, FG4497. And you can see that when this compound is added to cells grown in culture, you stabilize HIF-alpha as expected if you're preventing that prolyl hydroxylation from taking place. We had also made a mouse that ubiquitously expresses a HIF-1-alpha luciferase fusion protein. So this protein is now normally degraded in the presence of oxygen because of the HIF-1-alpha moiety. But now if you give these mice FG4497 by oral gavage, and then give the animals luciferin, which is the substrate for luciferase, the mice literally give off light, which you can then measure or monitor with a suitable camera. So you can see very quickly that this compound is bioavailable because you treat the mice and now the luciferase fusion gets stabilized. So eventually, Fibrogen did additional medicinal chemistry on that tool compound and produced a compound called roxadustat, which is an orally available HIF stabilizer. And the hope was that this would be useful for the treatment of anemia and maybe even in time for certain ischemic disorders. So here are phase 2 data from patients with anemia linked to chronic kidney disease, where at least part of the issue was a relative deficiency in erythropoietin. So the y-axis is plasma EPO and the x-axis is time. So here on day 1, here are the patients treated with roxadustat. You see a very nice increase in EPO compared to the placebo in red. You can also see, if you bring the patients back a month later, there's no evidence of pharmacological tolerance. You can once again turn EPO on or off with this orally available agent. Here again, our data from the phase 2 study showing that in a nice dose-dependent manner, there's induction of hemoglobin in these patients, or an increase in hemoglobin in these patients treated with oral roxadustat. Eventually, for a variety of reasons, phase 3 studies were conducted around the world, but for a number of reasons, the Chinese studies were completed earlier. So here are 2 phase 3 trials that were conducted in China, testing roxadustat for the treatment of anemia. And again, I declare my financial conflict of interest. Now, the scorecard for roxadustat as of today is the drug has been approved, and I think in 44 countries. But the FDA decided they'd like one more safety study because there was a suggestion that in the patients who had the most rapid correction of their hemoglobins, there might be an increased risk of thrombosis. And since I have a financial conflict of interest, it would be completely inappropriate for me to decide or discuss whether I think that's fair or unfair. Suffice it to say, there are now quite a few people around the world taking this drug as an alternative to erythropoietin or other agents. And I should also point out that in patients who have pre-dialysis renal failure, they often go under or untreated. So now there's an orally active alternative to EPO for them. Now, there are a number of these drugs in late-stage development. I highlighted in red daprodustat because daprodustat did cross the finish line in the United States and has at least been approved for the treatment of anemia in the setting of chronic kidney disease, at least for those patients who are already on dialysis. Now, it turns out this oxygen sensing apparatus is highly conserved throughout evolution. So here I'm showing you sort of an evolutionary tree. Here are the HIF-alpha genes, the EGLN or PHD genes, the prolyl hydroxylases, and here's the VHL gene, and FIH is another modifier of HIF we're not going to talk about today. And so you can really see that the system is very highly conserved throughout evolution. Not surprisingly, late in evolution, some of these genes were duplicated, which gave the system some additional richness. But this is very striking, and it begs the question why. And certainly the why isn't the cause von Hippel-Lindau disease. The why presumably relates to the fact that if you're an ischemic cell or an ischemic tissue, you need a way to adapt, to respond, and to hopefully survive in that low oxygen environment, and hopefully to restore oxygenation. And so based on purely sort of teleological arguments, you could then say, well, maybe drugs of this class would also be useful in diseases like heart attack or stroke, where part of the problem is inadequate oxygenation. And I should point out, in preclinical models, that certainly seems to be the case. So here are data from FibroGen and their collaborators, where they're doing experimental stroke models. And on the left, the animals got a vehicle, and on the right, they got another HIF stabilizer. And the white area is the size of the infarction. So you can see the infarct is smaller if the animals were treated with a HIF stabilizer. Now here, they cheated a bit, because the HIF stabilizer was given prior to the time of the infarction, which of course is not usually going to be a typical clinical scenario of someone coming into the ER saying, I'm going to have a stroke in 2 hours. Having said that, there is a benefit, even if you give the drug after the insult, up to the first several hours. And we also know there are settings where people are at high risk of having a stroke, such as people having recurrent transient ischemia attacks. Now, I also had 2 molecular cardiologists in training working in my lab, and they were interested in studying this system in the heart. And they educated me that you can actually do little mouse MI models. So you could tie off coronary arteries in a mouse. You could monitor the infarction by EKG, and you can also measure the amount of heart muscle damage. So the 2 of them took that compound I showed you a couple of moments ago. In fact, you've seen these panels on the left. But what I didn't tell you was they also did experimental MIs in these animals and measured the amount of heart muscle damage, which is what's measured here on the y-axis. So here, the placebo animals, there's significant heart muscle damage, which is reduced if the animals are also treated with this HIF stabilizer. Now, that's a pharmacological experiment. You can also do this genetically. So they had also created mice where they could inactivate the EGLN1 allele using a so-called floxed EGLN1 allele, and a version of pre-recombinase that gets activated by tamoxifen. And once again, they could see that acutely inactivating EGLN1 and stabilizing HIF would reduce the amount of heart muscle damage. Now, there's this very interesting, at least to me, interesting phenomenon in the laboratory called remote ischemic preconditioning. This observation made many, many years ago by others, that if you render one tissue ischemic in, for example, a rat or a rabbit or a mouse, seemingly that can protect other tissues at a distance. And of course, the fact that it was at a distance has led to ideas that maybe this could be neurally mediated, maybe this could be humorally mediated. Now, I was careful a moment ago to talk about this phenomenon being a laboratory phenomenon, because this is quite robust in the laboratory. Even we can get this to work. But it's been decidedly non-robust in the clinic when people have tried to implement this in clinical trials. In fact, there were several high-profile phase 3 studies that were reported in the New England Journal, where attempts to create this phenomenon, for example, by overinflating a blood pressure cuff repeatedly in patients about to have an elective heart surgery, did not lead to any evidence of remote ischemic protection. But we reasoned that if we really were going to harness this in people, we first had to understand the mechanism. And it certainly seemed rather crude to overinflate a blood pressure cuff multiple times as a way of inducing this phenomenon. So what Javed Moslehi and Ben Olenchuk did in the lab was, again, I've already introduced to you this mouse that has a conditional EGLN1 allele that we can inactivate by giving the animals tamoxifen. But now we're going to use a inducible pre-recombinase that's only active in the skeletal muscle, reasoning that limb ischemia would lead to skeletal muscle ischemia and inactivation of EGLN1. And I won't show you all the controls to show you that this really is restricted to the skeletal muscle. But here, once again, we could see that when we inactivated EGLN1 and the skeletal muscle alone, we still protected the hearts at a distance. So then Ben and Javed decided to swing for the fences and see if this was really due to a circulating factor. So they did these rather bizarre so-called parabiosis experiments, where they have a donor mouse, which is either a wild type mouse or a mouse where they can inactivate eglin-1 in the skeletal muscle. But now that mouse is physically joined to a recipient mouse such that they have a shared circulation. So now the experiment's going to be inactivate eglin-1 in the skeletal muscle of the donor mouse, and then measure MIs in the recipient mouse. And lo and behold, this still worked. So here I'm showing you a decrease in heart muscle damage, specifically when we inactivated eglin-1 in the donor mouse, in the skeletal muscle of the donor mouse, and then did MIs in the recipient mouse. Now, this begged the question, what's the mechanism? And this is a fairly dense paper, and I won't bore you with all the details. I'll just tell you, suffice it to say that when you inactivate eglin-1 in the skeletal muscle, it leads to an accumulation of that cofactor, which again is called either 2-oxyglutarate or alpha-ketoglutarate. In this cartoon, it's alpha-ketoglutarate. You can actually measure an increase in circulating alpha-ketoglutarate, which then drives a transamination reaction that leads to the accumulation of kynurenic acid, which Ben could show in his models was both necessary and sufficient for tissue protection. Now, it turned out that others before us had already reported that kynurenic acid was a tissue protective chemical in various ischemia models in the laboratory, but the mechanism of action was unknown. So more recently, we've been diving into this, and again, I'll just summarize a fairly dense paper by Greg Wyant that appeared in Science. Suffice it to say that kynurenic acid binds to an orphan receptor called GPR35, and upon binding, this receptor complex translocates to mitochondria, where in an ATP-IF1 dependent fashion, it actually promotes the dimerization of ITP synthase. And those of you who are experts will know that this is probably useful because during hypoxia, ATP synthase can actually, in a sort of futile way, start consuming ATP rather than producing ATP. But if you can force ATP synthase into a dimer, this doesn't happen. And this appears to be the mechanism for the cardio protection. Now, in the interest of full disclosure, I've already told you about these mice where we can conditionally inactivate the eglin-1 prolyl hydroxylase using tamoxifen. When you do that, you can see the paws get a bit redder and the vessels get engorged. And that's because these animals develop massive levels of polycythemia. And what I didn't tell you is if you let the animals continue to live in their cages, after a few more months, they die. And when my molecular cardiologist did echoes on the lab and these animals, they saw that the animals were developing what appeared to be dilated cardiomyopathy. Now, being a cynic, I said, well, that's not surprising because these animals now have a hematocrit of 80 to 90. Of course, they're developing dilated cardiomyopathy. But then, like any good postdocs, they did a better experiment that proved that their mentor, in my case, me, was wrong, because they created mice where they could now inactivate eglin-1 specifically and only in the heart. So these animals actually don't develop polycythemia. They've only inactivated eglin-1 in the heart. And just to make it a little bit easier for you to see the phenotype, they've also introduced a null allele for eglin-3, which is one of those other paralogs that is partially compensatory when you lose eglin-1. So on the left is a wild type. Oh, I'm gonna have to get rid of my pointer here, I think, to make this work. Hold on. Let's see if this one, I'm sorry. Let's see if we get this to work. Oh, I got to get rid of this pointer. Just bear with me. No, oh, come on. This worked okay in rehearsal. All right, well, if I can't get rid of this, you have to take my word for it. And the animal, and on the left, you can see very vigorous beating of the heart. This animal on the right, which lacks eglin-1, it just looks like a floppy bag that's not beating at all. And similar conclusions were reached by Ralph Showett, who had made a mouse that conditionally expresses a stabilized version of HIF-1 alpha in the heart. So these animals develop a reversible dilated cardiomyopathy. And we think this has implications for routine ischemic cardiomyopathy. And in fact, if you look at the mitochondria of these animals, you can see that they're actually beginning to lose their mitochondria. And that's because they're undergoing a process of mitochondrial autophagy, or mitophagy for short. So, I guess the idea is if you lack oxygen, you don't need your mitochondria for oxidative phosphorylation, and you begin to eat your own mitochondria. And you can see similar findings in human beings that have ischemic cardiomyopathy. So again, we think this perhaps has implications for ischemic cardiomyopathy, since one of the predictions would be if a heart is chronically ischemic, you'll have chronic high levels of HIF, and maybe some of these changes I just described to you will take place. And so, my punchline for this section of the talk is that it looks like acutely HIF is a good thing if you're an ischemic tissue, such as an ischemic heart. But at least in the heart, too much HIF for too long is bad and might contribute to the pathogenesis of ischemic cardiomyopathy. So I'm now going to get back to more solid ground for me, because I'm an oncologist by training, and to talk about the role of HIF in cancer. So it turns out there are several HIF alpha paralogs. There's HIF1 alpha, HIF2 alpha, and not shown here, HIF3 alpha. But at least in kidney cancers caused by VHL loss, the real problem seems to be an excess of HIF2 alpha. If anything, HIF1 alpha tends to constrain or prevent kidney tumor growth. And so that might explain why in many kidney tumors linked to VHL mutations, you don't even see HIF1 alpha expressed anymore. You only see HIF2 alpha. So what can we do about this? Well, fortunately, by the 90s, a number of drug companies were making VEGF inhibitors for the treatment of cancer. And we argued if these VEGF inhibitors were going to work in any solid tumor, they should work in kidney cancer because of this intimate link between VHL loss, HIF activation, and upregulation of VEGF. And the good news is we're up to, I think, 8 VEGF inhibitors that are now approved for the treatment of kidney cancer. But the bad news is not every patient with kidney cancer will respond to a VEGF inhibitor, and even those that do will eventually progress. So we have to figure out a way to do better. So you might argue, based on first principles, rather than targeting VEGF, we should target HIF itself. And based on what I told you, we should target HIF2 alpha. Unfortunately, the conventional wisdom was that HIF2 alpha was undruggable, but fortunately, 2 scientists who were then at UT Southwestern, Rick Bruick and Kevin Gardner, identified a potentially druggable pocket in the so-called PAS-B domain of HIF2 alpha, which is what I'm showing you here. And they did high throughput screens and identified chemicals that could bind to this pocket, and in so doing, induce an allosteric change in HIF2 alpha such that it could no longer bind to its partner protein, ARNT, and hence no longer bind to DNA. And eventually these were out-licensed to a company called Peloton that was recently acquired by Merck, and I again declare a financial conflict of interest. But the medicinal chemist at Peloton made these drugs or chemicals much more drug-like. They improved their potency, their specificity, and their bioavailability. And eventually, this is just to say, we sort of validated in preclinical models that these compounds did all the things you wanted them to do. They decreased HIF-dependent mRNAs, decreased proliferation, and decreased tumor growth. And eventually, a version of this drug called belzutifan, now called Welireg, went into phase 1 and 2 testing for treatment, the treatment of advanced kidney cancer in patients who had failed 1 or more VEGF inhibitors and had also failed so-called immune checkpoint inhibitors. So for those of you who haven't seen many of these are so-called swimmer's plots, where each horizontal bar is a patient on the trial and how long they were on therapy at the time of this analysis. For orientation, this vertical bar is 1 year on therapy. The black arrows are patients who were still on therapy doing well at the time of this analysis. And the yellow stars are patients who had a resist partial response. And so based on these promising data, this drug has now gone into phase 3 testing for the treatment of sporadic kidney cancer. Now, I'm going to digress for a couple of minutes. This is a story we've been having a lot of fun with, and that is to tell you the story of this notorious drug called thalidomide. And some of you may remember or have learned that in the 50s and 60s, thalidomide was available over the counter in many countries in the world for the treatment of morning sickness and insomnia. And sadly, when pregnant women took this drug, their children were at risk of having these horrific limb defects, and these came to be known as the thalidomide babies. And that's where the story would have probably ended, except some clinical investigators through, largely through serendipity, discovered that thalidomide-like drugs, such as now, for example, lenalidomide, are highly active in the treatment of certain cancers, and most notably multiple myeloma, which is a B cell malignancy. So now we have this drug that causes terrible limb defects, but it's a wonder drug. If you have multiple myeloma, how does it work? And we became aware of the work of Hiroshi Honda and colleagues who had immobilized thalidomide on a Sephiroth bead because the mechanism of action for thalidomide was completely unknown. And they identified a ubiquitin ligase. Now, it wasn't the VHL ubiquitin ligase, but it was the so-called cereblon ubiquitin ligase. So here, cereblon is the protein that binds directly to the substrates that were meant to be targeted for degradation. And in this paper, the authors suggested that thalidomide was simply a cereblon antagonist, that it inhibited the cereblon ubiquitin ligase. But some clinical investigators noted that if you looked at patients with multiple myeloma who initially responded to a thalidomide-like drug and then became resistant, often their myeloma cells were no longer producing cereblon. Conversely, high levels of cereblon tended to predict for responsiveness to these drugs. But at least the first observation we thought was incompatible with the thought that these drugs killed myeloma cells by inhibiting cereblon. If that were true, then loss of cereblon would be a form of cellular suicide. But instead, this suggested to us and to my colleague Ben Ebert, working independently, that cereblon, once bound to a thalidomide-like drug, must acquire the ability to destroy a myeloma oncoprotein. In other words, this drug's not an antagonist. It's actually a neomorph. And just to cut to the punchline, our group and Ben Ebert's group showed that these IMiDs, these thalidomides, the lenalidomides of the world, are actually what some people now refer to as molecular glues. And so in this case, this molecular glue allows cereblon to target two transcription factors called IKZF1 and IKZF3 for degradation. And it turns out these two transcription factors are absolutely essential for the survival of myeloma cells. Now, you might be wondering, what about those terrible limb defects I showed you? Well, the work of other laboratories taught us that the target here is a transcription factor called SAL4 that plays an important role in limb development during embryogenesis. And again, getting back to rare eponymous syndromes, one of the clues that SAL4 was the IMiD target was that there are individuals, rare individuals who are born with loss of function SAL4 mutations, so-called Holt-Oram syndrome, and they look like those children I showed you a few moments ago who were treated with thalidomide. Now, in closing, I showed you this this swimmer's plot a moment ago, and if you're a glass half full person, you could say this looks pretty good, especially in a phase 1, phase 2 trial. But clearly, many of the patients were not benefiting. But a truism in medical oncology is that most drugs work better in frontline settings rather than in late lines of therapy after patients have been treated with many other drugs. Now, I should tell you that these patients have been followed for a long time, and again, a handful of these patients are doing very well. But you can see even more clearly here, we need to do better. Here are the so-called waterfall plots showing you the best responses in terms of tumor shrinkage in these patients. So I started to say, truism in medical oncology is that most drugs work better in front lines of therapy. So we were able to convince Peloton and then Merck to treat 61 patients with von Hippel-Lindau disease who had measurable kidney tumors that were just being monitored in careful surveillance programs in an attempt to delay or prevent the need for repeated partial nephrectomies, which eventually would have left them functionally anephric. So to be in this trial, you had to have at least one measurable kidney tumor that had never been treated medically before. Parenthetically, many of these patients had other tumors linked to VHL disease, like hemangioblastomas and these pancreatic neuroendocrine tumors that are fairly common, but they had to have at least one measurable kidney tumor. So here now are the swimmer's plots in these patients. Once again, here's 1 year on therapy. Now you can see most of the patients are doing well, and many of them, again, are having either partial responses shown in gold, or I think there are a couple complete responses showing in the black triangles. And here's a longer follow-up where you can see the patients are still doing well. Many of the patients were doing well out at 3 years on therapy. Here the waterfall plots now, again, I'm a lumper rather than a splitter. So I would say all the kidney tumors had at least some measurable shrinkage. And I think the response rate is over 60% now. I mentioned some of these patients had other tumors linked to VHL disease. Here, the shrinkage of the hemangioblastomas in the different patients. And here's the shrinkage in a tumor referred to as a pancreatic neuroendocrine tumor. Importantly, these patients have been followed for many years prior to entering this trial. So in green here is the fate of these patients after they started belzutifan, but in gray is the 4 years prior to starting belzutifan. And every time you see a little triangle or circle or square, that patient's going back to the operating room to be operated on for some type of VHL-associated neoplasm. And you can see that once they start belzutifan, the rate of these surgeries being required goes down substantially. Now, I think statistics can be a little bit dry, so I'll just leave you with a couple social media posts from some of the patients on this trial. You can imagine if you're born into a family with von Hippel-Lindau disease, you've had sort of the sword of Damocles over your neck, and you've just sort of assumed that you're probably going to die in midlife since you saw this disease ravage your parents or your grandparents or your aunts and uncles. So here's a patient on the trial saying, I never thought I'd see this day. And they're describing that their tumors were getting smaller or were stable, or in some cases had disappeared altogether. Everyone likes a movie. I do have the permission to show this patient's face. This is a young man who was on the VHL trial. So here we go.
Hey everybody, it's Justin. I just wanted to give you a quick update. I am in a gondola right now in Taiwan. Over there is Taipei 101. The gondola is actually right by the Taipei Zoo. But I just wanted to give you a quick update and say I'm doing well. I'm enjoying my trip. If it wasn't for the PT2977 drug trial, I would have never been able to come out here and do what I'm doing right now. So I just wanted to thank Peloton, and I hope Merck will fast track this drug for a VHL treatment. So if you guys are listening, hopefully you guys will put it on the market to help VHL. But yeah, keep watching these videos. I'll be making more, and I'll get better at it, and I have to get the angles right because I kind of look fat, you know?
Yeah, I like that, because at that age, you should be more concerned about whether you look fat on your vlog as opposed to what your next CAT scan is going to look like. And I will tell you, I'm happy to report that he got his wish, because the FDA took the extraordinary step of approving this drug for von Hippel-Lindau disease based on the phase 2 data I showed you. Again, it was very helpful that the natural history of these patients have been followed so carefully. So I guess in closing, I didn't anticipate I was going to be a physician scientist. For those of you who don't know, I'm an MD. I'm not an MD, PhD. I'm a so-called late bloomer physician scientist. Again, I owe my scientific career to David Livingston. My conjecture is that if you were smart enough to make it through medical school and internship and residency and fellowship, and the curiosity hadn't been completely beaten out of you in the first year of medical school, then you could do this if you so desire. But again, I think mentorship is key, and being an institution that has a culture of sustaining and nurturing physician scientists. It turns out when you win the Nobel Prize, on one day you're supposed to make a donation to the Nobel Museum of something that was meaningful to you in your journey. And so I'll just share with you, this is my last slide. This is the toy microscope that my parents gave me when I was about 10 years old. So maybe they knew I'd be a scientist one day. I certainly didn't know it. And here is the equipment I had as a medical house officer on the Osler medical staff. I think you can see how frayed the tie is, but this literally was my tie from being an intern at Johns Hopkins. So with that, I will thank you very much, and thank you very much for your attention and for joining today.
Well, thank you so much. It's so hard to give virtual rounds and you can't see applause or people.
Yeah.
but thanks. And I invite everybody to either raise your hand or put questions in the chat. I just want to follow up on that second to last slide that you had there, the vanishing physician scientist. I think that's something that we worry about a lot in academia, and there's a lot of postulated reasons for that.
Yes.
But what do you think we need to do to help retain people on the physician scientist pathway? And let me start there.
Yep. Well, as I said, I'm pretty convinced if someone has, some curiosity and has the right mentorship, that they can do this. But having said that, I don't think that's working in a lab for 2 years, 50% of your time, and still having your beeper going off periodically. I mean, I think the formula is to really give someone about 4 years of protected time when they can really learn, the craft of being a scientist. And frankly, and perhaps understandably, a lot of medical centers no longer feel they can afford that luxury of helping, taking someone who might otherwise be providing clinical care and now having them sequestered, if you will, in a laboratory environment, actually learning how to be a physician scientist. So I can almost count on both hands now the number of institutions that with any regularity are training physician scientists, because again, it's expensive, it's a luxury. So you need an institution that can afford to do it and believes in doing it. And I think you do need a critical mass of mentors and role models. I don't think your mentor has to be a physician scientist to become a physician scientist, but I think it certainly helps. I mean, there were multiple days when I threatened David that I was going to put my white coat on and give up. And he knew where I was coming from. He knew what I was potentially giving up by maybe veering towards science. And he was able to help me maintain some perspective. But I think it's very helpful if you have some role models you can look to. And again, everything else being equal, I think having a mentor who's a physician scientist doesn't hurt.
Yeah, and I agree that protected time is key. Just out of curiosity, you mentioned that you never imagined that was going to be your career, and that you had, spent time as a chief resident, sort of fostering your clinical skills. How did you make it, if you didn't see somebody and know that's what you wanted to do, how do you make that decision to veer away from clinical medicine for a time?
Yes. So first of all, I did continue to see patients for about 10 years while I was a young physician scientist. And I think it's a very individual decision when and if you decide you're no longer going to see patients. And I certainly wouldn't force what I did on anyone in terms of when you make that decision. The sweeping statements I'll make, however, is first of all, I think if your choice is to be an A clinician or a B scientist, I think you should be an A clinician. So I think if you're going to try to do this, get the training to maybe make a meaningful contribution. And as we just said, I think that means getting adequately trained. So you're not just doing relatively pedestrian, derivative, descriptive type of work, but you can really start to do mechanism. In my own case, what I came to realize was what I liked most about medicine was problem solving. I like differential diagnoses, as I said, putting it together. And what I had neglected were two things. First of all, at a tertiary referral center like the Dana-Farber, most of the diagnostic work had already been done. So the only diagnostic dilemmas I faced were iatrogenica fulminans, as we used to call it. And secondly, as one of my professors taught me many, many years ago, common things are common, and every medical subspecialty or specialty has the bread and butter you're going to see probably a lot of over the next number of decades. And you better decide, is it going to be as interesting the 50th time as it was the second time? And so unfortunately in cancer, I was seeing a lot of the same things. And unfortunately, it was very clear that we had inadequate therapies for most of our patients. And so I decided to give myself a chance to contribute in any way I could.
Well, you've certainly made a difference. Dr. Del Rio, I see your hand up.
Bill, thank you. That was great. Again, it strikes me that you really were able to take observations at the bedside and then take them to the laboratory. And I think that link is, I think, what a physician can bring to science and what a physician can bring to the lab. Continuously, that keen observation at the bedside, I think, is critically important. And asking questions, right? It's not just treating the patient, but asking the why question. And I think going to the lab then really makes a huge difference.
Yeah, and I think, and I remember, I laugh at it now. When I first went into the laboratory, I was so impressed with things that should not have impressed me. Like, people who knew whether to use tris buffer or heaps buffer, or how you ran this gel, that you can learn, right? Just like you learn how to do an LP. But as you say, so much of science is having a nose for a good problem, having some scientific instincts. And if you're a physician, there's no shortage of interesting clinical phenomenon and conundrums to go work on. So I think it's a tremendous advantage. I think we completely agree on this, to have clinical training and then have the tools of science to go to work.
The other thing that I'm continuously amazed by, as I'm sure you, is how what a fine instrument our body is,
Yeah.
and the systems that work, and the elegance of an oxygen here, a hydroxy, and the widespread ramifications of that are mind-blowing to me.
Yeah, I completely agree. In fact, you won't be surprised. I'm infrequently asked, do we think we might win the Nobel Prize? And the honest answer is yes, but that's only because when we arrived at the answer, it was so beautiful, and you used the word elegant and satisfying, that we knew it was the kind of thing that wins Nobel Prizes. But as has been said before, that just illustrates that a lot of Nobel Prizes say more about the discovery than the discoverers. I mean, if the correct answer had been the 100th example of phosphorylation being used as a signal, there would have been no discussion of me going to Stockholm. We just had the privilege of marveling at how this beautiful solution had been arrived at throughout evolution. And so I also tell kids, that on one level was the prize, and then seeing the work follow through to new treatments, that's a prize. Everything else is a bit of a beauty contest.
Well, like I say, it's got to really be remarkable to know that you've made such a difference in the lives of so many. And I want to thank you so much for sharing that story with us. It really is inspiring.
Well, thank you very much. My pleasure. And again, hope to be there in person one day.
That would be great.
Okay.
Thank you.
Thank you. Thank you. Bye-bye.